Dear colleagues, I would like to present you today my thoughts on myopic traction maculopathy, a new staging system and guidelines of management. The recent literature on vitrectomy to treat MTM is not comforting, and as you can see, functional success is presented in 60% of cases and anatomical success in 82% of cases, but I disagree. And I think that if you don't give up on this patient, you can reach very good functional results by following the right guidelines. Let's focus first on pathogenesis of MTM. I think pathogenesis is based on the game of forces. If this is the eye wall, the vitreous and the retina, in a normal situation, you have centripetal forces that point to the fovea and keep the retina together. These forces are due to a combination of the action of Mueller cells, external limiting membrane and internal limiting membrane, and they hold the retina in a normal profile. Many centrifugal forces play against the only centripetal force. The forces centrifugal but perpendicular to the retina induce schisis and detachment, and the forces tangential to the retina induce foveal splitting. The centrifugal forces from the posterior eye wall elongate the eye posteriorly and detach the sclera from the retina. The centrifugal forces playing from the lateral eye wall enlarges the eye and induce detachment in the lateral part of the eye. Centrifugal forces from the vitreous pull the retina anteriorly, and centrifugal forces at the interface and tangential to the retina leads to the formation of holes. The forces can be also combined, so you can have centrifugal perpendicular forces from the eye wall and the vitreous, centrifugal tangential forces from the eye wall and the vitreous, and you will end up in a macular detachment combined with the macular hole. The study of the natural history of MTM that I personally pursued in the recent year demonstrated that MTM should not be divided in types, but in stages. This is an evolving disease. So I want to present you the MTM staging system, or MSS, that I have recently published and can be summarized in one single table that shows the evolution from stage 1 inner or outer schisis to stage 2 predominantly outer schisis in the deeper external layers that evolves into a combination of schisis and detachment, and that evolves into complete detachment without schisis. Notice how when the macula is completely detached, there is no schisis inside because the inner forces are released. For each of the 4 perpendicular stages, you can have 3 stages in the fovea. Stage 1 describe an intact fovea, but if the tangential evolution moves on, you can end up with a lamellar macular hole that can end up in a full thickness macular hole. The evolution can be from stage 1 to stage 4, or from stage A to stage B, or in oblique to stage 1A to stage 4C. The staging system will serve as a base for definition of this complex disease, prognosis, and guidelines to treatment. In fact, if you have a patient in the office in stage 1A and 2A, you can propose the patient to come back in 1 year, 1 year and a half. You have a lamellar macular hole, so you can decide to do something only if vision is dropping. But if you have stages 3 or 4 or C, you have to do something immediately. But what? In summary, I can tell you that retinal patterns of MTM, like schisis and detachment, should be solved by a macular buckle because perpendicular forces should be pushed, while foveal patterns, meaning holes, should be solved by pars plana vitrectomy, and maneuvers on the internal limiting membrane. In fact, tangential forces should be peeled. Again, the game of forces describe what to do. If you have a centrifugal force detaching the sclera from the retina, you should push the sclera to the retina with the macular buckle. But if you have a macular hole, you should treat the hole with vitrectomy and ILM peeling and flap. If you have combined forces, combine the treatment. I have published the guidelines for management. And in fact, this is the same table enriched in red with what I suggest to do stage by stage. In particular, please observe that under each standard photograph, I have added in green the average visual acuity that you can encounter when you visit a patient, although you know that visual acuity is influenced also by the anterior media and the entity of atrophy that the patient might have. But the MSS is not based on atrophy, only consider tractional changes. In blue, you see the time taken to evolve from one stage to the next. And in red, you can read the management. In stage 1 and stage 2, I advise to do nothing, just observe because the evolution is very slow and visual acuity is good. In stage 1B and 1C, I advise vitrectomy, but in 1B only if vision is dropping. In stage 3A and 4A, just to buckle, don't touch the retina from the inside. In stage 2B, 3B, 4B, I advise to apply a macular buckle and add vitrectomy in a second step only if the lamellar hole remains symptomatic. When there is a full thickness macular hole and the schisis or detachment, you can combine a macular buckle and pars plana vitrectomy. What is a macular buckle? A macular buckle is a device made to shorten the axial length at the posterior pole. Old models were posteriorly sutured sponges that have been abandoned because the strategy was too difficult and dangerous to be applied. In literature, you can find a whole list of types of macular buckle that actually are not used. And this is the model that I have been using since 2009 and then modified to make it smaller and shorter. And this is how I make it directly in the OR. I use a titanium stent and a sponge, and the lateral arm is covered with a silicone sleeve. So as you can see, I create a tunnel with a 17 gauge needle into a sponge, and then I insert the titanium stent into the sponge. The titanium allows me to customize the shape of the buckle as an L, but you can also change the angle, you can twist and adjust to the shape of the eye. So it offers a good amount of freedom to adapt the shape of the buckle to the shape of the eye. And then you can easily insert the light into the sponge, and that helps to use transillumination. If you are using just a macular buckle, I advise to start with the paracentesis to lower the intraocular pressure. One fiber optic is in the pars plana. You can use twin lights and then use the other light into the sponge. This is the actual insertion of the macular buckle in the superotemporal quadrant. It's the easiest quadrant. Don't use any other quadrant, because in that quadrant you will not find any oblique muscle and you will reach easily the fovea. Use a panoramic viewing system to locate the buckle. Centration is a key factor in this type of surgery. And then the suture can be applied anteriorly, very close to the insertion of the muscle, either the lateral rectus muscle or the superior rectus muscles. You can use 1 or 2 sutures to fix the buckle and avoid the tilting. These are different videos. In this case, it was in a combination with the vitrectomy, but the procedure is the same. Location of the buckle and suturing in a very well exposed area. In this case, I was using intraoperative OCT that is extremely helpful in confirming the correct position of the buckle. Here I was doing live surgery in Floretina a couple of years ago, so you can see the in-focus OCT showing a huge detachment with the macular hole. It was a great help in guiding my maneuvers. It was a combination of vitrectomy, peeling, and macular buckle, and I will show you the post-op results in a few minutes. In this case, I implanted a macular buckle only with the guidance of intraoperative OCT without the need of any fiber optic. Recently, I explored the efficacy of the L buckle in order to be able to use a commercially available product. And it seems to work as well as the off-label model, although it does not offer the freedom of customizing the shape. And these are some pre and post-op examples. You see on top a retinal detachment with intact fovea, stage 3A, very low visual acuity. But on the bottom, you see a great functional and anatomical result showed with the wide field OCT. These are 23 millimeter scans. Look on top, the huge detachment with the lamellar macular hole, extremely threatening. If you do vitrectomy in a case like that, you risk to induce a iatrogenic full thickness macular hole. Vision was very bad, but the result was again great. You can see on the bottom, the retina is attached, the hole is closed, and visual acuity is very good. And this was a stage 4C detachment with a full thickness macular hole. If you do vitrectomy with that huge staphyloma, you have a good chance to attach the retina under gas and keep the hole open. And then when the gas will go away, you have a very good chance of a retinal detachment relapse. Then if you add silicone oil, you can attach the retina, but when you remove silicone oil, the retina will redetach. Then you might use heavy silicone oil. So you will end up with an attached retina, a hole open, glaucoma, and a non-seeing eyes. By applying macular buckle with vitrectomy, gas, and ILM peeling, you can obtain this type of result. The retina is attached, the hole is closed, and visual acuity is increasing. This is pre-op stage 3B, post-op retina attached. Pre-op on the left, retinal detachment with an intact fovea, and on the right, the retina is attached. Pre-op stage 4A, post-macular buckle only. And this was the case that I operated in Floretina, stage 3C. You can see the huge scotoma on the microperimetry top left, and on the bottom, the post-operative result 1 month after surgery. The scotoma is gone, the retina is attached, the hole is closed. I recently checked the patient. Her vision is 0.8 right now. So in conclusion, I suggest to follow the MTM staging system and follow the guidelines of treatment. Choose the model of buckle that you prefer and help me validate the MSS. I'm available anytime if you want to reach me. Bye.